Rahim, and good afternoon, everybody. I'd like to welcome you in this grand round for this afternoon. Our speaker for today is Prof. Hani AlMezaine. He is the head of anterior segment cornea division in King Saud University Department of Ophthalmology. Prof. Hani is having a tremendous experience in the medical retina, especially in microbiology and related diseases. And I'm sure with this time of experience and research in that topic, he will enlighten us about one important rare infection that we are facing once in a while in our clinic, which is Acanthamoeba keratitis. And inshallah, Prof. Hani in these coming few minutes will update us about how to manage those patients and how to tackle that disease in a way that will help our patient and help the service. Prof. Hani, please go ahead.
Thank you, Prof. Abdullah. Today we'll speak about the Acanthamoeba keratitis. As you know, Acanthamoeba is very unique and special infection. I hope that all of you will join and you enjoy this lecture. In this talk, I will highlight on the backgrounds of Acanthamoeba keratitis, diagnostic tools, including in vivo confocal microscopy, polymerase chain reaction, and in management, I will shed the light on the first FDA-approved Acanthamoeba medication, topical steroid use, controversies, deep anterior lamellar keratoplasty for Acanthamoeba keratitis, and photoactivated chromophore for keratitis, crosslinking, what is known as back crosslinking. Okay, so Acanthamoeba is potentially a devastating corneal infection. It's a cause of a painful, progressive, and potentially blinding keratitis. Despite improvement in diagnosis and treatment, prolonged morbidity and severe visual loss occurs, unfortunately. Some historical background. In 1973, the first report of Acanthamoeba keratitis. As you see, this is a recent date. I'm sure that there was an infection reported before that, but because might be lack of clinical suspicion, difficulty in detection, it was not recognized before that date. In 1984, the first recognition of contact lens as the major risk factor for Acanthamoeba keratitis. And in 1989, 250 cases were reported in USA. So why the increase in the incidence of Acanthamoeba keratitis? Probably one of this is the increased contact lens wear population. And this, as you know, it will increase the risk by 10 to 15 times. The second probable cause is the greater awareness among clinicians. Also improved diagnostic techniques. We have now PCR, we have confocal microscopy. These might improve the detection. Also changes in the environment, like flooding. Also emergence of more virulent strains. So we might facing now a more virulent organisms that it's become appear clinically. So 2 out of many known species of Acanthamoeba is Acanthamoeba castellini and Acanthamoeba polyphagia are responsible for most of infections we see. If we go to the structure of the Acanthamoeba, the inactive cystic form, this is, as you can see, it is a polygonal structure with a thick double wall. It contains nucleus, mitochondria, it contains lipid droplets. These cysts usually are resistant to many environmental conditions. So they might remain viable for many years. It can reach to 25 years until it is exposed to a food source. The cyst, as I told you, is resistant to harsh environments. It can tolerate dehydration, extreme temperature. It can tolerate from -20 to plus 47, and many chemicals. It tolerates pH between 3.8 to 9.7. It is a highly resistant to host immune response, antimicrobials, so it is difficult to be eradicated. What about the active trophozoite? The active trophozoite contain nucleus, mitochondria, lysosomes, and a central cytoplasmic contractile vacuoles. As you can see here, there's a contractile vacuoles in the trophozoite body, which expel water when the trophozoite moves. As you can see here, this is the trophozoite. While it is moving, the hyaline pseudopodium slowly extend from the amoeba. This called phlebodia, and it helps the trophozoite to motility, and the motility. So the trophozoites, during this movement, it phagocytoses any small particles encountered, like bacteria, fungi, so it feeds on these organisms. But once the trophozoite is exposed to air, then it ruptures easily. So this is the cycle of the movement between cyst and trophozoite. As you see, cyst is always in dormant state, and it moves to trophozoite once nutrition is available and no drug pressure. Once the cyst moves to trophozoite, then it will start to replicate and move everywhere, unless it is faced by stress, lack of nutrition, or drug pressure. So this is the cycle in the environment. This is the excistation and incestation of the trophozoite. The cyst will move, will get out, and then it will enter again. This is the electron microscopy. It shows you the excistement of the cyst. This is the trophozoite coming out of these cysts. What about Acanthamoeba and our water? The distribution of Acanthamoeba and various water sources in central region of Saudi Arabia was studied. They took multiple samples from different water sources, and they look for the presence of Acanthamoeba. And they found that the recreational water has a high percentage. As you can see here, this is the types of samples they took. They took from the tap water, from drinking water, from swimming pools, recreational water like water fountains or artificial waterfalls at parks. Also, they take samples from borewell water. This is the stored tank in dates farms. So they found that recreational water has 26% of the specimen containing the Acanthamoeba. Stored tanks contains 37%. Swimming pools, imagine, contains 16%, despite the chlorinated water and usual disinfection. Drinking water, and this means the bottled water is zero. Tap water contains 1%, 10%, sorry. So what is the predisposing factor for Acanthamoeba infection? As you know, contact lens wear of all types, including orthokeratology, is a main risk factor, but it is not the only one. Corneal trauma due to vegetable matters, exposure to contaminated water, or inadequately sterile water or tap water. All these are risk factors for Acanthamoeba infection. Acanthamoeba keratitis is range between 33 cases per million of contact lens wearer per year. In one study, 75% of patients were contact lens wearer. Among these, 40% was among the soft lenses. So the soft lens is a main risk for the Acanthamoeba infection, followed by the extended wear or other types of lenses. And 22% is for rigid gas permeable lenses. So it's the least associated with infection. So why contact lens wearer are at higher risk? Because the adherence of trophozoite to all types of contact lens, mainly the soft, is high. Other cause is the contamination of the contact lens storage cases and solutions. The behavior of disinfecting the contact lens is important. So high risk when you use the homemade or tap water for cleaning the lenses. Also, this omitted disinfection. Some people or some patients, they don't use even the disinfected solutions. One important risk is swimming with contact lens. As we see prior to that, the presence of Acanthamoeba, even in well chlorinated swimming pools. Another risk is the micro trauma by the contact lens, and we will see what is the importance of micro trauma to the epithelium and how this helps in the attachment of the trophozoite to epithelium. Another risk is the role of bacterial contamination, and we will come to this in the coming slides. In May 2007, the FDA announced an outbreak of Acanthamoeba keratitis that was associated with moisture plus multipurpose solution manufactured by Advanced Medical Optics. Most available multipurpose solutions are effective against trophozoites, but not cyst. So cyst will remain viable even in the multipurpose solutions, unless this solution contains hydrogen peroxide. This chemical will kill the cyst. Several studies found that 400 to 800 per 10,000 asymptomatic contact lens wearer had lens storage cases were contaminated with with Acanthamoeba. So if we take samples from the storage case of the contact lenses, even with the contact lens solution, we will grow Acanthamoeba. However, the rate of Acanthamoeba keratitis was only 0.01 to 1.4 per 10,000 contact lens users. So fortunately, the infection rate is low, despite these numbers. Normally, humans have high resistance to Acanthamoeba infection due to the high concentration in the lacrimal fluid of immunoglobulin A, lysozymes, and lactoferrin, which have anti-protozoal activity. It was postulated that micro injuries of epithelium, tear film composition, eye surface pH, and the level of anti-Acanthamoeba IgA antibodies in tears might play a role in the development of the infection. What about Acanthamoeba infection in non-contact lens wear? Mothers et al. In series of more than 200 cases of Acanthamoeba keratitis found only 40% of cases associated with contact lens use. And they postulated that epitheliopathy may be the predisposing factor. In Asian countries, the majority of AK occurred in non-contact lens wear. And this is being secondary to corneal injury. This scenario has been identified as the major cause and the major risk factor for infectious keratitis in rural areas. As a bacterial reservoir, several species of bacteria that can cause human diseases, such as Pseudomonas, Mycobacterium, Listeria, are also able to infect and replicate within the Acanthamoeba species. As you can see here, this is the cyst which is full with Pseudomonas. The presence of Pseudomonas inside the Acanthamoeba trophozoite help the attachment of the trophozoite to the hydrogel gel contact lens. As you see here in this cartoon, these cartoons show you the process of the attachment and invasion of the trophozoite to the inside the cornea. Number one is the attachment, and the attachment here is between the glycoprotein receptor, which is on the surface of the epithelium, attached to the trophozoite by mannose receptor. This is the mannose receptor, the red one, is attached to the yellow, which is the glycoprotein on the surface of the epithelium. The expression of this glycoprotein increased when the epithelium is subjected to micro-injury. This micro-injury might be due to the contact lens or due to the scratch or any trauma. And if there is a lot of expression of this glycoprotein, then we will have a lot of attachments of more and more trophozoites, making the infection more severe with a lot of production of toxic factors. In this stage here, in the epithelial damage and upregulation of matrix metalloproteinases, here in this stage, there is a production of what is called mannose induced protein 133. This protein, which is produced by the trophozoite, this acts on the epithelium to destroy the epithelium, destroy the keratocytes, and makes apoptosis of macrophages. Further penetration in the stroma, this also will cause direct damage to the stroma keratocytes by the production of MIB 133, matrix metalloproteinases 1, which is collagenase, and also the glycoprotein ecto-ATPase. All these components will act on the stroma to destroy the keratocytes, to necrotize the collagen, and this will aid on further deep penetration of the Acanthamoeba trophozoite. Also, the trophozoite likes nerves, so it will move through the perineural nerve and will migrate through nerves. Usually, trophozoite does not go beyond the decimal because the extensive neutrophil here in the anterior chamber prevent the trophozoite to enter inside the anterior chamber. So trophozoite, as I told you, cannot penetrate this membrane. It can, but it is very rare. And this is because the intense neutrophil response in the anterior chamber. Trophozoite are probably not efficiently immunogenic. Why is that? Because there is evidence of lack of stromal neovascularization in Acanthamoeba keratitis. Also, we don't see a lot of lymphocytes response during the infection. And also there is lack of inflammatory response around the intact organism. So the main immune cell which usually deal with Acanthamoeba is macrophages. Macrophages act against the trophozoite and trying to be the first line of defense and eliminating the trophozoites. What is the clinical features of acanthamoeba keratitis? As you know, the infection is having a chronic course of relapses and remissions, and this is due to the encystment and excitement of the cyst and the trophozoite. Usually it presents unilaterally, but it was reported rarely bilaterally. The patients usually present with bilateral blurred vision, photophobia, tearing, and severe pain out of proportion to the clinical signs. This pain is presenting feature in 95% of cases. Contact lens wearer typically seeks medical help late because they are used on minor trauma to the eye, minor irritation, so they present at a later stages. What about the clinical signs? Usually non-specific. The early signs usually non-specific and misleading. Conjunctiva, injected, chemosis, follicles, and limbitis. This is the limbitis which we see in early stages of Acanthamoeba keratitis. Usually these cases, they don't have eye discharge, and this is a differentiating clinical sign when you compare it to bacterial keratitis. The epithelial signs which present with Acanthamoeba is usually pseudodendriform epitheliopathy, or sometimes they present with microcystic edema or a recurrent epithelial defect. This is what we mean by the pseudodendriform epitheliopathy. It is very similar to herpes, but the difference that this doesn't have round terminal bulbs, which we see usually with herpes. So it's very important to keep high index of suspicion for contact lens wearer presented with this picture, especially when they are not responding to antiviral medications. A nice case report was done by Prof. Abdullah, who was demonstrating radial keratoneuritis, which is a very useful sign, but it's not always present. It's present in 50% of cases. As you can see here, the radial keratoneuritis, and this is the patient presented with this keratoneuritis, and it has a relapse once the patient stopped the steroids, as you can see here. This is another reported case and their series showing you here nicely the infiltrate with the Acanthamoeba trophozoite. Sometimes only one corneal nerve can be affected, as you can see here. You can see here, only this branch is involved with the radial keratoneuritis. The perineural infiltration could be due to amoeba migration along corneal nerves. And this is associated with also release of proteases, which damage the nerve tissue and cause the severe and significant ocular pain. However, when we take the corneal sensation, usually it is diminished. Keratoneuritis is not pathognomonic for Acanthamoeba keratitis. You can see it with Pseudomonas also keratitis. What about the stromal signs? Usually the stromal signs, the marked infiltrate, is not obvious until 6 weeks of the onset of the infection. And this which makes the diagnosis more difficult and delayed. Why is this delay in the presence of a stromal involvement? Is due to the slow division of the trophozoite. How the stromal signs present? It can present as multifocal infiltrates or ring-shaped infiltrates or disciform keratitis looks like lesion. This is what we mean by multifocal stromal infiltrate, the satellite lesion. As you see here, small infiltrates all over here. Ring infiltrate or Wesley immune ring. This is due to polymorph nuclear leukocytes precipitation or antigen antibody complex precipitation, as you can see here. All these cases of ring infiltrate. Others believe that the destruction of the stroma by various enzymes is the cause of the ring infiltrate. Also, this ring infiltrate can be seen also in bacterial or mycotic keratitis. In cases of mixed infection, I mean Acanthamoeba plus bacterial or mycotic co-infection, we see here in this type of mixed infection the dense infiltrate with hypopyon. And this makes the diagnosis more difficult. Sometimes the stromal infiltrate will present as only corneal edema with disciform reaction or endothelial plaques. Corneal vascularization is uncommon in Acanthamoeba keratitis unless it is associated with bacterial infection. One entity which is occur in 10% of these cases is Sclerotitis. The pathogenesis of this entity is unclear, but it is usually when it occurs, it is associated with a high morbidity. Usually these cases is severe cases, and most of these eyes is difficult to manage and might be lost. Why is the sclerokeratitis? It could be due to direct invasion of the sclera by the trophozoite or inflammatory process mediated by T cell. So T cell vasculitis might be the cause. As you can see here, the infiltrate reaching up to the sclera. Also in this case here in long-standing scleritis. Other signs which we can see also with Acanthamoeba is sterile anterior uveitis with hypopyon. Cataract also can be seen, and the cause of cataract could be due to the toxicity of the medication, chronic inflammation, steroid, or vascular thrombosis. Iris atrophy, persistent dilated fixed pupil can be seen also as long-standing infection. If left untreated, Acanthamoeba can spread back to the retina, causing serous chororetinitis, retinal vasculitis, CME, and disc edema. Also, an immune-compromised, we can see endophthalmitis. As you can see here, this is a case of endophthalmitis secondary to Acanthamoeba. Also, fatal meningoencephalitis in depleted cases can be one of rare complications of Acanthamoeba. So diagnosis. The diagnosis is a challenge in these cases, and it needs a high index of suspicion. It's very important to keep always high index of suspicion in the microbial keratitis in general. Due to the relative rarity of the infection compared to other causes of bacterial and viral, usually it is misdiagnosed. And imagine that around 70 to 90% of the Acanthamoeba keratitis cases is misdiagnosed and leads to delay in diagnosis. Delay diagnosis of less than 18 days between the onset of symptom and the start of treatment has a better final VA, and it's help us avoiding the therapeutic behavior. Although the diagnosis is presumptive and can be made clinically or with confocal microscopy, the definitive diagnosis is only made with cultures, histopathology, or PCR. What about in vivo confocal microscopy? This tool is extremely useful, rapid, and non-invasive. It can create high resolution, high contrast optical section, strongly dependent on the experience of the observer, the technician also, and it requires a cooperative patient. Also, with this technique, we can monitor the response of the treatment and the recurrence. It has a sensitivity and specificity of more than 90%. It's more sensitive in early superficial infections because you can have a better resolution to detect the cyst mainly. So it is only reliable to detecting cyst, and it has, as you can see, it appears as a double wall refractile round body of around 10 to 15 millimeter in diameter. And this is the target, what we call target image. These are the target images. As you can see here, these are the pathognomonic for Acanthamoeba keratitis. Trophozoitis usually looks like stromal keratitis and doesn't help in diagnosis. What about the laboratory diagnosis? We usually take samples from the contact lens storage case, corneal scraping, and corneal biopsy. And these scrapings, usually we send it to Gram and GEMSA. This is GEMSA stain. As you can see here, the Acanthamoeba cysts. Sometimes we use the histochemical, histopathological staining like Infiltrate and AlMezaine stain. And you can see here the small cysts here in the corneal stromal tissue. The main stain for Acanthamoeba is calcofluor white stain, which is a fluorescent dye which only stains cysts. It is specific and sensitive in detecting the organism. This is the stain, and you can see here the cysts. Also, another stain which is used is modified trichrome stain. It can also detect the cysts. The culture is the gold standard in the diagnosis. And usually we use a non-nutrient agar with overlying enteric bacteria. In cases of severe infection, amoeba are usually visible after 24 to 48 hours. Some cases may require weeks to obtain the final result. Therefore, we must be primarily guided by history and clinical finding. And this is very important. You have to have a high clinical suspicion. Sometimes you will depend on that to manage the patient. In cultures, usually we observe the wavy tracks. This is the wavy tracks of trophozoites. Once the bacteria consumed, then the trophozoite will insist. As you can see, this is the cyst chains of cyst in the culture media. What about PCR? PCR is, as you know, is rapid, more sensitive and specific than traditional cultures. You can detect, as you know, a single Acanthamoeba organism may contain more than 100 copies of ribosomal DNAs. So the detection of very small number is possible using the PCR. This table shows you the sensitivity of different tests. As you can see, the PCR has the highest, reached to 84 to 100% detection rate. This is followed by confocal microscopy. It's reached to almost 90% sensitivity. Followed by the culture reached to 77%. Histopathology, it can reach to 65% detection. What about the treatment? Treatment is extremely challenging with a potential of failure. Early diagnosis is crucial in the successful treatment. It is resistant to most available agents. Because the currently available treatments are both toxic and lengthy, accurate diagnosis is essential. We cannot start anti-Acanthamoeba medication without a strong evidence or positive culture or positive PCR that we are really dealing with Acanthamoeba. The trophozoites are sensitive to most available drugs, antibiotics, antiseptics, antifungal, antiprotozoal, but cysts are not. Cyst is very resistant. After starting anti-amoeba treatment, the inflammation commonly gets worse due to the death of the organism and the release of antigens. The period of therapy usually is long. It's reached to 6 to 12 months. And when discontinued, close observation is needed to avoid the recurrence. Medical treatments. The main treatment groups is bigonides. Bigonides disrupt the membrane function. Two examples of bigonides is polyhexamethylene bigonide and chlorhexidine. These medications under the category of bigonides. Diamidines inhibit the DNA synthesis. One famous medication is the proline, which is propamidine, and bentamidine. Also, aminoglycosides like neomycin is used in the treatment of this condition because it kills the trophozoites and the bacteria also with it. Imidazole is amoebostatic and it's effective against trophozoite only, like systemic ketoconazole, itraconazole. These are imidazole group. Now there is a new generation of azoles, which is trizole. This is in vitro cysticidal, has cysticidal effect. One of them is systemic voriconazole. Voriconazole is now replacing the use of ketoconazole and itraconazole in the management of Acanthamoeba because it has a better oral absorption and good corneal penetration in inflamed cornea. So what is the strategy of treating the Acanthamoeba? Usually we start with epithelial debridement. This is important because it debulks the load of infectious organism. It also decreases the food source for the Acanthamoeba. It's provide adequate epithelium for culture sensitivity, and removing the epithelium facilitates drug penetration. Commonly we use from the bigonide chlorhexidine, and usually we start the chlorhexidine and proline 1 hourly. We start aggressive in the early stages. Neomycin, another topical medication, sometimes used, and also systemic voriconazole is an important part of the treatment. Many of these topical medications, many topical drops are not commercially available in the US and need to be specially ordered. The early use of high-dose dual therapy, bigonide, diamidines, helps to eliminate trophozoite before it invades deeply and before the cyst fully mature. This is very important. Failure to kill or eradicate all cysts will result in the recurrence of the disease. When used individually or in combination, the efficacy of these drugs range between 35 and 86%. Individuals with more severe diseases or high or history of steroid use before diagnosis are more likely to fail initial treatment. So a patient who is exposed to steroid before it comes to you and you start the anti-Acanthamoeba, usually they have poor prognosis. Usually we add antibiotics as prophylaxis and to treat also if there is a mixed infection. Monotherapy like Vigamox can be adequate. Topical systemic non-steroidal is important to control the pain. Cycloplegic is also is important. If we are dealing with scleritis, scleritis, as you know, indicates a worse outcome, and it needs an anti-inflammatory medication. Usually, oral non-steroidal anti-inflammatory medication is adequate, but if it fails or not enough, then we go to high doses of systemic steroid. Plus minus systemic immunosuppressive agents like cyclosporine to control the scleritis. Miltefosine, this is a new medication for Acanthamoeba keratitis. This is the only and the first approved FDA approved medication for Acanthamoeba keratitis. The mechanism of action is not fully understood for this drug, but it inhibits mitochondrial activity. It can also destroy the plasma membranes and induce apoptosis in the amoeba cells. Early case reports support the use of miltefosine as an adjunctive treatment for Acanthamoeba resistant cases. However, literature surrounding its use is still growing. Further study are warranted to clarify its role, what is the optimal timing of starting this medication, the dosage, and the route of administration. What about topical steroid? As you know, topical steroid is a big controversy in treatment of Acanthamoeba keratitis. Steroid will decrease the immune response. It can be used with caution once you control the infection. But this control cannot be guaranteed. As you know, the organism go in cyst and between cyst and trophozoite stage. So in cystic stage, you might feel that the infection is controlled, but once you start the steroid, the trophozoite appear again, and then you will have a recurrence, which is difficult to be treated. So while it helps control the inflammation, it leads to the transformation of the cyst to trophozoite with consequent risk of worsening and recurrence. On the other hand, this is one of the advantages of steroid, that it helps the trophozoite to appear, and then it will be susceptible to the Acanthamoeba drug. There are several potential benefits for the using of steroid. Decreasing the pain, limit corneal vascularization, and control the inflammation. A study from Moorfields Eye Hospital showed that the potential of benefit of topical steroid in treating pain and discomfort are not associated with worse outcome when they started the steroid 2 weeks after the anti-amoebic medication. Steroid for Acanthamoeba keratitis is not recommended in the absence of anti-amoebic therapy, particularly in the presence of signs of aggressive disease, such as ring infiltrate. In these cases, the steroid use associated with poor outcome. Avoiding the use of empiric topical steroid by general ophthalmologists is very important. We see a lot of cases coming to the ER from the private cases of keratitis started on topical steroid and presenting with a devastating condition. So it's very important for the safety of the patient to limit the use of steroid to cornea specialists. In vivo study showed that topical steroid, even at low doses, promote increase in number of tryptozoids produced by existment in the stroma. This exposed the patient to high risk because there is a great amoebic load and increased pathogenicity. In Moorfield Eye Hospital, it has been shown that the use of steroid prior to the inhibition of initiation of anti-amoebic therapy is associated with 4 times increased risk of suboptimal outcome, defined as PA less than 20/80 and perforation and the need for keratoplasty. What about the surgical options? Delay in diagnosis and initiation of treatment leads to a too fulminant disease to be controlled medically. The role of keratoplasty here is either therapeutic to eradicate the infection or optical to for visual rehabilitation. The indication for therapeutic BKB is usually in large infiltrate extending or threatening the limbus, or worsening despite intensive medical therapy, or perforation, which is not amenable to glowing. Keratoplasty in general should be avoided in active stages, even if there is extensive corneal involvement. An attempt should be made to achieve control of infection medically as far as possible. Ideally, keratoplasty is postponed until more than 6 months after the resolution of the infection. The largest published case series in keratoplasty for Acanthamoeba keratitis showed that therapeutic BKB associated with 13-fold increased risk of poor outcome, vision of less than 20/200, and the need of multiple keratoplasty, and the other additional ocular surgeries. So poor prognosis with therapeutic keratoplasty. They concluded that the prognosis of keratoplasty differ markedly when performed for therapeutic purposes compared to visual rehabilitation. Where possible, keratoplasty should be delayed until the eye is uninflamed and medically cured. The cyst is highly immunogenic, and this will increase the rejection rate. The success may be part due to the debulking of the number of organisms, allowing the anti-amoebic and host immunity to eliminate the remaining organisms. BKB for Acanthamoeba keratitis has good long-term prognosis when it is done in when we control the infection and we control the glaucoma. Once the infection has spread into the peripheral cornea and reached the sclera, achieving surgical cure is markedly diminished. Graft survival after Acanthamoeba keratitis should be kept to the minimum size required to decrease the risk of rejection. All patients undergoing surgery should be on anti-amoebic therapy and should be on this therapy for a long period after the keratoplasty to prevent recurrence. What about deep lamellar keratoplasty? Deep lamellar keratoplasty has a better surgical option. Is a better surgical option than BKB because it is having less chance of rejection and graft failure, particularly in inflamed eye. Compared to BKB, successful lamellar, but without perforation, has the advantage that you debulk the infection without the risk of intraocular spread of the infection through the anterior chamber. However, DALK could be less effective than BKB in eradicating the infection. Large trepanation and deep dissection will decrease the recurrence in DALK. So in comparative study between therapeutic BKB and DALC for infectious keratitis, and Anshua et al. Reported that infection recurrence is 13% after DALC and 12% after BKB. Early surgical timing to eradicate active keratitis poorly responsive to medical therapy may be increased with DALC, and so it is more curative. What about photoactivated chromophore for keratitis? Cross-linking, what was called back cross-linking. The microbial effect thought to be mediated through a combined effect of the direct UVA-induced DNA damage and the release of reactive oxygen species by the riboflavin reaction with light. This will induce oxidative DNA damage. Back cross-linking appears to be effective alternative to standard treatment for infectious corneal infiltrate according to a preliminary result of phase 3 randomized controlled trial presented by Emilio in the ESCRS 2020 this winter. What is the advantage of back cross-linking? In case of mixed infection, unlike drug therapy, it kills both organisms in the same time. Because back cross-linking makes the cornea more resistant against enzymatic digestion, the resulting scar of the infection usually smaller than when you use the drug therapy alone. It kills even most drug-resistant cases, bacteria like MRSA. Back cross-linking overcome the diagnostic dilemma of non-responding infectious keratitis. So we avoid the wasting time with ineffective treatment in a rapidly progressing infection. High fluence back cross-linking using 7.2 joule per centimeter square for 30 minutes, given with anti-amoebic therapy, resulted in last pain relief, reepithelialization, and eradication of Acanthamoeba parasite. The post-operative relief in pain is due to the suppression of inflammation and transient reduction of subepithelial nerves. They claim in this case report that it has a potent effect on the cyst in advanced and refractory infection. Systematic review and meta-analysis for collagen cross-linking for infectious keratitis by Lamperini shows that 10 out of 11 eyes with Acanthamoeba keratitis were successfully treated with cross-linking combined with anti-amoebic treatment. However, results from experimental study are less encouraging for management of Acanthamoeba keratitis because they think there is no anti-trophozoite activity and no effect of corneal cross-linking on the intensity and the severity. And this study is proven in both in vitro study and in animal model. Histological study shows that cross-linking have only limited impact on killing trophozoite, cyst, or bacteria. So the issue of cross-linking is still on debates, but meta-analysis is supporting its use. In conclusion, Acanthamoeba keratitis recently emerged as a clinical problem and has been one of the most difficult corneal disease to manage. It is an extraordinary disease. It is caused by organisms that can burrow through intact epithelium, spread and multiply in corneal stroma, and stay there in both dormant and active form. Early detection by keeping high index of suspicion cannot be overemphasized. Methods like confocal PCR allow earlier diagnosis and treatment, which will lead to better outcome. Increasing awareness of Acanthamoeba keratitis, early diagnosis, and effective new therapeutic approaches hopefully will save many eyes. Effort should be directed toward prevention of the disease by educating contact lens wearer for proper lens hygiene. Thank you.
Thank you, Prof. Hani, for this nice illustration and new knowledge that I'm sure all the audience learn from this 1 hour presentation. Just want to stress 2 points that you mentioned already is the starting of steroid empirically in microbial keratitis. I think that is making the outcome is poor in all stages of any disease of bacterial or viral or fungal or acanthamoeba as well. So avoiding the steroid use, I think, is a take-home message, one of the important take-home messages from this presentation. The other thing which I face in these patients, sometimes when you are following them closely in hospital, like daily, sometimes we had the intention to change or do some surgical intervention or starting medication. So I usually said to our colleagues, the fellows and residents, if they are stable, just discharge them and see them as outpatient in weekly basis. Especially they are not like the aggressive one that it will metastasize or go to the sclera in hours or in days. Usually they are indolent, they take time. لكن احنا دائما we had the intention once the patient is complaining of pain, sometimes changing or drawing some of the medication. أحيانا هذه will يعني make it longer for the recovery. I can thank you for the nice presentation, and I will open the floor for discussions. If there is any questions, can unmute or chat. Meanwhile, until we have a question, Prof. Hani, do we have out of this medication that you listed, since we are having problems in providing them in the pharmacies and they are not really available, which out of these 4 or 6 categories, which one we will be a more effective one in treating acanthamoeba?
The mainstay of treatment is bigonide, and bigonide is chlorhexidine and proline. These are essential because this 2 medication, when you give it topically, it has an effect on both cyst and trophozoite. And it should be started aggressive and early before it goes deep. If it goes deep, then most of the time you will lose control of the infection. Also, we have to add to these medications systemic voriconazole. Systemic voriconazole, it's proven that it has an excellent penetration in inflamed eye, and it has a good effect on the acanthamoeba. Hopefully, with this new FDA proven medication, we will have a better control. This medication is given orally, and they claim that it is better than even voriconazole.
Is it available in our local pharmacy or hospital?
No, even in America, in the States, they order it from Canada. Even the medication, one of the slides I mentioned that proline and chlorhexidine, many of the centers in the States is not available. So they order it from Canada or from Mexico to bring it. Yeah. So they have the same problem as we have.
One point just to emphasize for the resident and the beginner of ophthalmology practice, that we have the emphasis of acanthamoeba, as Prof. Hani said, it is challenging in both the behavior from to cystic and from the also penetration from epithelial, superficial to deep, and the response to the treatment. So all these points are challenging in managing those patients. This is what makes it peculiar, and we don't talk a lot about the type of bacteria or fungal, but in acanthamoeba, we have these 3 challenging in terms of diagnosis, in terms of treatment. This is why it is sometimes, yes, it is rare. Like, if you face it, it will be difficult to manage. But if you pick it up early and treat it well, the outcome will be good.
Yeah, the problem that these cases, occur in young patients and usual contact lens. So if they lose their eye, they are really, it's big, it's big issue. To stress the issue of using the steroid, um, last month, as you know, we received one case of Acanthamoeba. We received it in the ER. Uh, it's the professional diagnosis, Acanthamoeba. We received it in the ER. There was only just epithelial changes, just SPKs. Topical antibiotics given by our ER, given appointment for follow-up. The patient disappear, comes after 2 weeks, treated in private with topical steroid. When the patient who presented with topical steroid, they present with ring infiltrate, severe infection. So this one case tells you how really we are suffering about um, the widespread use of steroid in keratitis, which is a medication which has سلاح ذو حدين. If you don't know how to use it, then you might have really a devastating infection, which is difficult to be controlled.
Okay. Okay, I think we are on time now to start the other. This is another one question, just bumping now. If you just give me 1 minute, Prof. Hani, to read it. Do we start the anti-acanthamoeba based on the clinical picture, or we have to have an evidence culture or convoker?
This is a very good question. Usually, we start Acanthamoeba based on either PCR or culture. However, if you have a very strong suspicion, a patient who is having really history suggestive of using contact lens, poor hygiene, using tap water for cleaning, and you have a picture going with Acanthamoeba, and you use all the antibiotics, which the patient is not responding, and you rule out, fungal elements, herpetic, then you can start anti-Acanthamoeba based on a high suspicion, depending on your history and clinical judgments.
Okay, I hope that was clear, Dr. Abdullah. I saw a raised hand by Dr. Faisal.
Thank you.
Yes, go ahead, Dr.
Okay, so thank you, Prof. Hani. Thank you, Prof. Abdullah, for the nice topic. Just my question is, you mentioned that the steroid very cautiously to start after getting the infection get controlled. So do you recommend it to use a steroid after, for example, 1 week of anti-acanthamoeba treatment? And if you decide to go for the penetrating keratoplasty, when do you start or initiate steroid post-operatively?
Yeah, this is I mentioned about the topical steroid, that it shouldn't be started before 2 weeks of intensive anti-acanthamoeba medication. And once you are sure that you really control the infection, and you start gradually, you start with a low dose and see the response of the keratitis. So not before 2 weeks of controlling the infection. If you are doing the BKB as therapeutic, I will not be, and you feel that you remove the infection, but still there is remnant of infection. You are thinking that it's still infection is there. I will not start the steroid. And I will not care about the grafts to fail, because the aim of the treatment here, the therapeutic BKB, is to remove the infection. But if you are doing the BKB for optical reasons, then you can start the steroid immediately after the surgery, provided that you are putting the patient on anti-acanthamoeba medication.
If you allow me, Prof. Hani, to comment on this, and also Dr. Turki, just a minute before you answer, you get your question. Regarding the steroid issue is tricky in these cases. I agree that it will be a very limited use of steroid. I'm not in a hurry to use it even after 1 month. And you lose anything if you wait more prematurely, then you will have a problem. Like the other use of steroid that I challenge one or two patients of mine with steroid, and again, the acanthamoeba, it will be cystic. And if it is cystic, it will be resistant to whatever you are giving. If there is an indolent infection that is not going and not progressing in like 1 or 2 weeks, maybe you can challenge this with the steroid. But again, the point of Prof. Hani said, this need to be done under close supervision and with the cornea specialist. You need to follow these patients closely, because you just initiate the steroid to take this acanthamoeba from cystic to trophozoite back, and then you kill it with the anti-amoebic medication. This is the point. Sometimes you succeed, sometimes you fail, but that is one of the challenges in the treatment.
Agreed.
Dr. Turki, go ahead, please.
Assalamu alaikum. Thank you, Hani. Thank you, Prof. Abdullah, for this nice presentation. I want also to stress and strongly agree with you that I know some colleagues, they regret starting and following the protocol of Morfield to start Pred 40 after 2 weeks. So they said, if we will treat more cases, we will just wait for clinical improvement, and sometimes we will not start steroid, or we will start it after 3 weeks. Because if they follow the protocol, they will start it after 2 weeks. So I strongly agree with both of you. The other point for the residents, when they want to do scraping for acanthamoeba, it is a little bit tricky, because we have 2 sets for scraping. We have the standard and the supplemental. The supplemental, you have to request it by if you suspect acanthamoeba. So once you get the media, it will be very cold. And you cannot do the scraping immediately. You have to wait 20 to 30 minutes until it become in room temperature, so the media, then you can do the scraping. If you do it immediately while the media is cold, sometimes you will not get the accurate results. Sometimes you will get false negative as per the technician in the lab. And thank you.
Thank you, Turki. Thank you.
The last question from Dr. Suleiman Tregi. Thank you, Prof. Regarding the scleral involvement, if there is no response to oral nonsteroidal, how safe it is to start systemic steroid for scleritis during an active infection?
This is very tricky. The scleritis, it could be due to the invasion of the organism, and theoretically, if we give systemic steroid, we are making the condition worse. If the scleritis is reactive due to the inflammation, steroid might help in controlling the infection. To be honest with you, this is a difficult situation. Once it reached to sclera, that's why it is clear that once it's reached to the sclera, most of the time we lose the eye. What do you think, Dr. Abdullah? You have experience on scleritis.
I agree. When it reaches to the sclera, this mostly it is a bit late to treat. But again, oral nonsteroidal will not be a good thing to give, even early or late. Oral nonsteroidal is not something we will use. Topical steroid, again, may be used. But again, if you want to avoid, it is good to start. If you think there is scleral involved or near to the sclera, maybe this is a good indication to do BKB before it reaches to the sclera.
Yes.
Okay, so I think we are Now we'll proceed, I think, for quiz, Prof. Hani.
سم صوتي يقطع بروف عبد الله.
Yeah, I think is
Yes,
it
yes.
scheduled
We'll
for
move to
quiz
quiz
now?
now.
Yes. Okay.
Thank you, Prof.
Thank you all and good luck.